Hi, my name is Ryan Verla. This is video 3 of my video presentation project of gold standards for COPD exacerbations. And we will be talking today about a little deeper dive of the few indicators of prevention and maintenance for COPD. So for smoke cessation, with the right resources and the right acknowledgement from the patient, up to 25% long-term success rates is viable for those that want to quit smoking for the long term. Just these 5 assessment systems that you want to think of: ask, advise, assess, assist, and a range. You want to ask, are they using tobacco? For how long? For how long has it been going on? Just to get the information first. Advise. You need to let them know that smoking is bad and you want them to quit. Assess, determine willingness and rationale as patient's desire to make a quit attempt. Ask every tobacco use if he or she is willing to make a quit attempt or at this time. Assist, aid the patient in quitting. So making sure that the patient understands, like, if they want to quit, here's how we do it. Either smoke cessation, pharmacological treatment, or pulmonary rehab. And then arrange. Make sure that they have getting in contact with the right people to further help them along their way for freedom from this disease. Vaccinations. So to keep in mind, these are for the patient's COPD, but they get the vaccinations against the influenza virus and the pneumococcal virus. So getting both viruses help reduce the serious illness and death in COPD patients because, again, they have such immune compromised system. They need to be able to be very protective of what they are around of, and giving them the opportunity to be able to sit and be around other people that could be sick, or people that they don't have no control over who is actually sick around them. It has been shown to reduce the incidence of community-acquired pneumonia in COPD patients aged less than 65 years with an FEV1 of less than 40% predicted in those comorbidities. So it's actually very good for those that would, that are younger than 65 to know that, hey, they are less likely to have pneumonia-acquired diseases if they get the vaccine for that. So pharmacology. Let's talk about whether there are some medications that can be used for the maintenance and the prevention of COPD. So one of the main ones is bronchodilators. Of course, these are going to be medications which it helps open up the airways, and that can be done with a beta-2 agonist that is specifically responsible for relaxing the airway of the lungs, and SABAs, short-acting beta agonists. So these are the ones that are going to be pretty fast, and these are going to be the ones that are more readily available and often used more of. So they help our central to symptom management. They are commonly given on a regular basis to prevent or reduce symptoms. They are regular or an as needed of SABA or SAMAs. They improve FEV1 and the symptoms. So if you do a combination of the two, they are superior compared to either medications alone in improving FEV1 and symptoms. So a second thing what you would see is an anti-muscarinic, anti-muscarinic drugs. So these are the drugs that block bronchoconstrictions. They are basically the SAMAs, or the tiotropium, the ipratropium bromide medications. These are medications in which they help reduce those bronchoconstrictions, or people with asthma. That's probably the clinical assessment you see with those patients. I also use LABAs and LLAMAs. These significantly improve lung function and the dyspnea, health status, and reduce exacerbation rates. LLAMAs have a greater effect on exacerbation reduction compared with LABAs, so that can decrease hospitalization. Combination treatment with the LABA and LLAMA increases FEV1 and reduces symptoms compared to monotherapies. So getting a combined therapy drug is really good. We can also do LABA. LABA can reduce exacerbations compared to monotherapy or an ICS with a LABA. So tiotropium improves the effectiveness of pulmonary rehabilitation and increasing exercise performance, and theophylline exerts a small bronchodilator effect in stable COPD, and that is associated with the more modest symptomatic benefits. So pulmonary rehab. Pulmonary rehab, the benefits of COPD patients with pulmonary rehabilitation are considered, and rehabilitation has been shown to be the most effective therapeutic strategy. Again, building that community with folks. You have someone that you're accounted to. These people are going to hold you accountable. They're going to remind you of why you're going through this fight, why you're going down this road, why you're putting yourself through the ringer for you to live a healthy lifestyle. Pulmonary rehabilitation improves your dyspnea, your health status, and exercise tolerance in stable patients. They are also reducing hospitalizations among patients who have recent exacerbations. So, you're no longer going to the hospitals more often because you're taking the time, you're taking the energy, you're taking the necessary requirement to really hone down and develop stronger, more healthy lifestyle habits to maintain a relationship with other people that are in the same boat as you, that are keeping you accountable and keeping you safe and keeping you healthy to achieve those goals that you might have, whether that's staying alive to watch your grandkids grow up, or staying healthy enough for you to take care of your own self as you get older and not need full assistance from someone else. So education and self-management. Education alone has not been shown to be effective. So self-management intervention with communication with a healthcare professional improves health status and decreases hospitalization and emergency department visits. So that's why we need that. That's why we need these integrated care programs to help demonstrate and to benefit at that time. So I just want to give you like a little rundown of some medications that are used for different categories. So for your SABAs, for levoalbuterol, regular albuterol, or salbutamol, which is your regular albuterol. Your long-actings or your LABAs, you have arformoterol and formoterol. So these are the longer-lasting acting agents. Anticholinergics, so it's for inflammations. You have your short-acting, your long-acting for those. Short-acting ibuprofen bromide. Long-acting, you have your tiotropium medications. A combination of the two that could be used in one device, such as a salbuterol, or it's a little bit hard to read, so excuse me, I'm sorry. Like a combination of the two, so you have a formoterol with the ibuprofen, or an acting combination of LABA and a anticholinergic, one device. So that could be like your formoterol with a glycosylprominium. Those are good combinations of drugs that can help with the maintenance and the prevention of COPD. Pardon. So the closure local would also be like methylaxines. You have your aminophylline, theophylline. They're the only two that are used here. Combination of LABA acting beta agonist plus a corticosteroid. You want to deal with, you want something that's going to target that inflammation, your chronic bronchitis and your emphysema symptoms. And that's what that's what your anticholinergic, your corticosteroids will help. So that's going to be your budesonide, or your fluticasone. These are going to be the drugs that really target those areas and help with inflammation. And then you have your phosphodiesterase 4 inhibitors. So these are the patients that are born with that alpha 1 deficiency that cause COPD. So at the moment, there's only one medication, and it's going to be down here at the bottom, right here. So that's going to be everything that we're going to be covering in video 3 of our presentation. We just wanted to make sure that we understand why some factors are used and why some are not, why you would use a corticosteroid when using a treatment, combination of the two. And I just want to say thank you again, and have a great day.